next panel is entitled Beyond the Transition to Biosimilars. I'm going to introduce the moderator, and he will introduce the rest of the panel. Michael Sine is the former GM of TEVA Canada, and he will introduce his panelists. Michael.
Thank you very much, and thank you, everyone, for joining us right after lunch. And right after lunch is a tough crowd, so we'll keep it animated and keep you alive with what we have to talk about. So I want to introduce the panel, have a couple words, and then we're going to have our panel discussion. So right beside me is Dr. Tijana Fazlagic, and she's the Executive Director of Therapeutic Assessment and Access, part of the Pharmaceutical, Laboratory and Blood Services Division at the British Columbia Ministry of Health. Dr. Fazlagic's responsibilities include leadership of the formulary management, specialty medicines, precision medicine, and genetic services, and the business team. Dr. Fazlagic represents BC on various committees, including the Canadian Agency for Drugs and Technologies in Health and Pan-Canadian Pharmaceutical Alliance. She holds a Doctor of Pharmacy degree from the University of Florida, a Master of Science, and a Bachelor of Science degrees in Pharmacy from the University of Saskatchewan. Welcome, Dr. Tijana.
Thank you.
Our next panelist, Mr. Alan Lawless, and he's the Executive Director of the Non-Insured Benefits Branch, Insurance Division at Mantioba Health Seniors and Long-Term Care. He was previously the Director of Formulary Management and Exception Drug Status Unit in the same branch. The Non-Insurance Benefits Branch provides departmental leadership, the planning, management, and administration of sustainable, publicly funded insurance programs for prescription drugs, ancillary services, and devices. Alan was also a pharmacist, ran a 24-hour Shoppers Drug Mart pharmacy as well. Jody Cox. Jody is the Vice President of Federal and International Affairs with the Canadian Generic Pharmaceutical Association and has led federal, legal, intellectual property, and international trade files on behalf of the off-patent pharmaceutical industry in Canada for the past 16 years. Jody's been actively engaged in work with the International Generic and Biosimilar Medicines Association since 2009. She's chair of the IGBA Global Biosimilars Week Task Force and past chair of the IGBA International Trade. More than 25 years of experience, so you have quite a bit of experience with these panelists and for our topic today, which I find very important. You know, a lot of the audience here in healthcare, you intersect with biologics and biosimilars. But even if you don't, as I was talking to people before we got up here, it hits on a personal level. Some of you personally are involved with biologics or a biosimilar. And if you are not, as a caregiver, you are or will be. How important is this topic? Biosimilars and biologics are the larger budget than even the total generic industry in dollar terms. Over $8 billion of spend goes into the biologic biosimilar market. And of that $8 billion, biosimilars is just over $1 billion of it. So we're talking about now pinpoint therapies, where people are able to have treatments for rheumatoid arthritis, oncology, severe debilitating migraines, and get the results that they need that they've never been able to experience before with the old traditional model of one pill and we hope it fits all. And with that comes the challenges of expense. And so that's what we're going to discuss with the panel in depth. And one of the first questions I have, and I'm going to start with Dr. Tijana, is the road to where we are today had a lot of pitfalls for the Canadian experience. And maybe you can talk to a little bit what your experience has been over the years until we got to right now with the biosimilars.
Sure, thank you. So I was involved in 2019 when BC was the first province to go ahead with the biosimilar initiative, and where we mandated a switch from the originator products to the biosimilars that were available at that time. But at that point, in 2019, the biosimilars were already in the market in Canada for a number of years, and only about 10% of patients at that time were on the biosimilars, and the rest of the patients were non-originators. And if you look now, in BC, patients that are on pharmacare plan, but also the ones that are through private coverage, about 90% are on the biosimilars, and only about 10% or less are on originators. So we've come a long way. We have provided, safe and effective alternative option to the patient. We have saved a lot of money over that period of time. So reporting BC came out in May, I believe, and indicated that we have saved over $700 million over 5 years for BC pharmacare plan, just that one plan. And that money, then, we were able to reinvest into other innovative therapies that have come along. So, we've come a long way. It doesn't mean that it's perfect, and there's lots of pitfalls and things that need to be addressed, but it's, we're moving in the right direction.
Thank you. Excellent. Alan, your thoughts?
Yeah, I think with Manitoba, we're the opposite spectrum of where BC was, where BC is the first, Manitoba was the last. That being said, Manitoba was one of the first provinces to implement a tiering policy in the biosimilar space. A decision wasn't made, early as far as implementing a non-medical switch initiative in Manitoba, but once that did get greenlit, it was something that the branch moved on very quickly. And I think it was interesting when we talk about specific pitfalls that we noticed in Manitoba, that we had the benefit of learning from initiatives that were rolled out across the country. We were able to look into each province and see, what happened, what were they doing, get a lot of feedback from our partnering jurisdictions or our colleagues as far as, what were timelines, how did they see switching happening, what were some of the issues that developed. But in Manitoba, it's very specific, and there's one thing that stands out is, we rolled out our initiative very quickly, and this one thing that came to the forefront was with biosimilar insulin. In Manitoba, regulatory amendments were not enacted as requested by the College of Pharmacists for many years in specific areas of expanded scope of practice for pharmacists, and one of them was therapeutic substitution. And because that hadn't happened, when the switch initiative was announced, pharmacists aren't participating in the biosimilar switch for insulins. So that's required, physicians to shoulder that work, a lot of administrative burden, but not much we can do because the college wasn't supportive of them participating without the regulatory amendment in place. So that's one of the biggest issues that we've seen and the biggest pitfall we've had.
Okay, great. Thank you. Jody.
Yeah, so I've been involved in biosimilars since 2007, back in the days when we called them subsequent entry biologics. And, I think in Canada it was a slow start. That's how things sort of started initially. I think even going back 10 years ago, it wasn't clear from a manufacturer's perspective that you could actually get a biosimilar approved in Canada. I mean, there were a few approvals, but, in terms of extrapolation of indications, all of these different things, where, products that were approved in other jurisdictions weren't necessarily getting the same approvals in Canada. And, I think all of those issues have now been addressed, and, it's very clear that biosimilars can be approved in Canada. We're up to 64 approvals. There's another 26 submissions under review right now for 19 different reference products with, another 4 or 5 to come in fairly short order. So in terms of that landscape, it's improved substantially. I think if I'm going to find a silver lining of a slow start is, there were a lot of things that were happening in Europe where Canada was able to learn lessons in terms of best practices and, through the Pan-Canadian Oncology Biosimilars Initiative, for example, the jurisdictions were able to come together and talk about what were the needs for the various cancer agencies, what were the needs for implementation, and came together and effectively did that. Same with the switching policies. As Tijana outlined, they developed sort of a playbook for the jurisdictions and have had successful rollouts. And as Alan has said, successful as well in Manitoba in terms of their rollout as well. So we've come a long way, and things are going well, although I would say on the private side, it's a bit mixed. So that would be another area where there's more to be done.
Right.
Yeah.
Good. And, when you mention about other regions, for instance, whether it be the Nordic regions and those countries, but even the U.S., where the U.S. certainly hasn't seen the kind of uptick in biosimilar use as they once wanted. And when they look at Canada, very excited about the switch program that is on. But this dovetails into a question about Health Canada. and their role in this. Because right now, biosimilars require each supplier of a biosimilar to go out and detail physicians. That's very expensive, very burdensome, time for the physician and the clinic to now deal with multiple new players in the market for these things. So I guess my question to the panel is about Health Canada's role, whether it be regulations, interchangeability, and other comments you want to make. And just before we came up, we were talking to Health Canada, so I asked everyone to be gentle on Health Canada wherever you are out there. So thanks. Go ahead, Dr. Tijana.
So from my perspective, Health Canada has come a long way. Just before we rolled out the biosimilar initiative, they did come with a stronger statement endorsing biosimilars, that they are safe and effective and should not result in any difference compared to originators. So that was great timing. We really appreciated that. I think the next step from my perspective is looking at that interchangeability. We are not quite there yet. It does put a bit of a burden on prescribers because the patients still have to go to a prescriber and get a new prescription for a biosimilar, or even if they're switching between the biosimilars. So definitely, in the next decade, I would like to see that change.
Good, thank you. Alan, your thoughts?
Yeah, no, I think Health Canada definitely is doing, a good job. And one of the things that, we would like to see, at least from a Manitoba perspective, is to help streamline the approval process. And just for example, when we talk about biologic, biosimilar, and non-biologic complex drugs, and making sure that when regulatory approvals are provided through Health Canada, it's done in a manner which really helps to streamline not only the health technology assessment route, but the PCPA route as well.
Right.
Because that'll really help in not only making expedient decisions, but allowing for easier formulary management control when it comes to dealing with drugs in that space, because there have been a couple of issues that have popped up that have been a little more challenging to navigate, just as far as a biosimilar switch initiative. So that would be the one thing that we would like to see a little more consistency in.
Yep, good.
Yeah. One thing that I think was a bit of a game changer for biosimilars in Canada was Health Canada started doing a really good job of communicating how they review and approve the products, how they regulate, how the products are manufactured and so forth. That helped to build confidence in the products, and I think it really was important in laying the foundation for the biosimilar switching policies just writ large. And there's a number of great resources. If you haven't seen them on Health Canada's website, they have physician handbooks, they have infographics for patients and so forth. And the fact sheet really, I think, is biosimilars in the words of Health Canada in terms of how they're to be used, and that's really a bit important. I think as manufacturers, where we have concerns with Health Canada right now is resourcing. And I think that's not unique to biosimilars. We see that in the generic space. I think we've heard a lot today about, accelerating access to medicines, both in terms of the approval times and, sort of working their way through the system. And, I think, we're seeing submissions that are picked up later than they used to be, and, questions coming later than they used to. And really, timely approvals is sort of the key to all of this in terms of advancing access, making sure that jurisdictions and private insurers and companies have access to biosimilars medicines as quickly as possible, so those savings can start to accrue. So I don't know if there's any decision makers out there for Health Canada, but the proper resourcing is really a key to success here for pharmaceuticals.
Great, thank you. I think one of the important things for the audience and those that are streaming in and us as panelists is patient access. But let's not forget the caregiver that also is, for more reasons, having to go on this journey and this experience with the patient. And something Alan and I had been talking about a few days ago is about patient access and challenges. And it was raised in a couple of the panelists this morning about access to remote and rural areas and some of the challenges. It also dovetailed with PPNs and PSPs, because the patient service programs for every biosimilar could have different PSP providers that they're working with. And it's not always necessarily known by the pharmacy or other stakeholders who's working with who might be more efficient. They're all supposed to be the same. So maybe my ask of the panel is to maybe talk about patient access and caregiver, and what the feedback you have on the experience that you've heard, whether it be you've seen that or anecdotally in your realm. Alan, do you want to start?
Yeah, for sure. I think I'm going to speak specifically to the rural remote experience because that's something that's always front and center in Manitoba. When COVID-19 happened, a lot of patients who were getting centralized infusions in Manitoba, either through Winnipeg or Brandon, transitioned to getting infusions in rural and remote hospitals and health centers. And what that has done is change the dynamic substantially for the health system, where now a lot of the administrative burden and administration of those medications is happening in rural and remote locations, and it's become a challenge not only because of staffing levels, because of high turnover rates, but it has been more convenient for the patient. So I know one thing that Manitoba we hope to address, in partnership with our health system, is some of those situations that have developed to ensure that not only patients have access, ease of administration is in place, but it's not creating an unforeseen burden on the health system that wasn't anticipated. And then part of that too is also, if we look at some auto refilling practices that are occurring with providers and through distribution networks. We've seen a substantial buildup of biologic and biosimilar medication in rural health centers where they're either not being administered or patients aren't receiving product. And we don't know if that's because of patient support program policy changes or just because of that transition back to rural and remote locations. So that's something we're going to be working with the health system on trying to navigate, just because it's not only an extreme cost to either drug plans, to the public drug plan who's paying for the majority of the drugs, but it's also becoming a challenge for logistics and storage and distribution in the health system.
Yep, good. Any comment, Jody, Dr. Tijana?
Tijana, do you want to go first?
So from BC perspective, rural remote, obviously a challenge as well. And when transitioning from one product to another, different patient support programs, different infusion sites, patients may have to go longer distances. So definitely that's been one of the challenging areas as we go on this journey and continue on it, because we have some new biosimilars coming that are also infusions. In our Northern Health Authority, for the most part, because the infusion sites are not up there, it's mostly done through health authority clinics or the hospital sites, which puts burden on those sites as well, because they have other patients take care of it. So we're working through those things. One other thing we heard about, the patient support programs, the thing that seems really simple, but it's been a big challenge, is, the patient support program has to get in touch with the patient. And if they're changing support programs, they have to get registered. Well, nobody picks up the phone anymore these days, and a lot of the phone numbers don't say who is phoning. And so that was a big challenge, we can't get hold of this patient. The patient has to switch to a different product. The time is running out, and the patient support can't get hold of the patient. Yeah. So a little bit of education for everyone around that.
Great point.
Yeah, and of course the biosimilar sponsors are providing high quality patient support programs, and that's one of the first questions I think manufacturers receive when we do our PCPA negotiations in terms of the quality of the PSPs. And I know there's a lot of work, and there's similar kinds of challenges as well for the originator biologics as well. So it's it's a Canadian geography challenge, I think, that we're all committed to working through for sure. And when it comes to PSPs, of course, in Canada, the situation is very different than international. We were speaking earlier about some of the international considerations, and in a lot of jurisdictions, if you need an infusion, you just go to the hospital and it happens, and it gets picked up on the public side. And that's not our reality in Canada, so that's part of the reason maybe we're having challenges, but just throw that out there as well. I know you were interested in international, Michael.
I was.
Bringing in the international.
A few days ago, I wanted that international piece. Thank you, Jody, for putting that in there. So we've talked about patient and the caregiver, and I welcome everyone in the audience again to think of questions that you're going to want to ask in about 10 minutes' time, including about the patient and the caregiver, because I think it's an important area. And along this line is thinking about other stakeholders in this community of the biosimilars and biologics. We're talking about physicians, we're talking about nurses, we're talking about wholesalers, pharmacists, pharmacy, the whole ecosystem that is adapting very quickly to not just biologics, but in the biosimilars where, again, by definition, they're similar but not the same, and you have a multitude of them. And I wonder if I could ask the experience of the panel, again, about these stakeholders. When you have people from, whether it be the patient or even a physician, asking about the differences between the similarities of the biosimilars and how they relate back to the biologic, and the interwoven of the wholesaler, or if it's one distributor, and how is pharmacy reacting to that. Just open idea about the stakeholders, the ones you feel comfortable maybe about discussing as well.
So in BC, we still pay a special fee during the 6-month transition period to the pharmacist and to physician to acknowledge the time that it takes to have these conversations with patients or with caregivers as they. So, you know, it's been 5 years now. We should normalize this process of transitioning, but yet we still feel compelled because they do need that extra support and time. So we do that. But it's challenging with the patient support, kind of tying back to patient support programs and how the drugs are distributed. A lot of these products go through specialty pharmacies, so it might be tied to just one specific specialty pharmacy, and now when you're switching to a different product, you might be tied to a different pharmacy. And it gets confusing from the patient point of view, gets challenging from the transition perspective, and then it's also challenging on the pharmacists as healthcare providers, because now they don't necessarily have a relationship with that particular patient, and they need to build those. From the physician point of view, I mean, it still takes time. I think, you know, over time, the physicians in the areas like rheumatology or the GI or diabetes, they're more familiar with these products now. They've been around for a long time. But each time we enter a new area, there is new education that has to happen. So osteoporosis is a new space that we've just entered recently, and that needs to be education of the prescriber, and then that trickles down to the patient, pharmacist, and all that.
Okay, thank you. Alan.
Yeah, and you know, the opposite spectrum of BC is Manitoba is not paying a special tariff or fee for physicians to implement the switch, and we're also not paying pharmacists, you know, in the therapeutic substitution for insulin, for biosimilar insulin, because of the you know, the aspect of not being able to work in that space because of the regulatory amendment. So that's definitely created some challenges. However, we have received a lot of positive feedback, not only from pharmaceutical companies, but from clinicians as well, of how big of a role patient support programs have taken in Manitoba to help manage the transition. And we've received specific feedback that a lot of patient support programs are not only conducting education sessions one-on-one for clients, but they're also doing group education sessions. So it's interesting how we haven't paid, you know, a special fee to either physicians or to pharmacists in this space, but receiving feedback that maybe patient support programs have stepped up to fill some of that void and to really help with the administrative burden on physicians, because our biosimilar switch initiative was announced and rolled out very quickly. And the transition time of 6 months, I know, was going to be challenging in certain therapeutic spaces for the clinicians. So it's been good feedback that the PSBs have stepped in.
Thank you.
Yeah, and maybe to speak to a different province. So, another, the largest province in Canada went forward with their biosimilar transition policy as well. And when they were doing their rollout, they were having biosimilar monitoring tables. So every month they'd bring together the patient organization, the clinician organizations, industry, a number of different stakeholders, to provide updates on what was happening and for people to ask questions, to share learnings, and address issues as they were arising. So I think that communication was really helpful in the Ontario context. And the other thing I just wanted to mention as well is Health Canada, I think, has been there and supporting the jurisdictions as they've been rolling out. So Health Canada has had a very open approach. So if patient organizations needed information or clinician groups wanted to talk to them about biosimilars, there was an open door. They were out doing the presentations as they were requested, and I think that also was very important.
Okay, good. I think one other thing that all of us are very aware of and the media has highlighted is supply stability in Canada when it comes to medicines overall. So whether it be innovative or generics, there's always the challenge as things constantly change and evolve that there are going to be supply challenges. And what's interesting about the biosimilar side is if there could be 4 or 5 biosimilars to file to want to come out on time, but 2 come out right at the same time, and there's going to be a delay for the 3 others, the switch program would effectively get all of the patients into the first 2. So the other 3 may say, I'm not going to launch. I'm going to cancel the program. There could be some vulnerability in supply. And I'm going to ask the panel if there's, A, any noticeable supply concerns today. Are we concerned about supply issues in biosimilars and biologics tomorrow like we're experiencing in the medicine supply on the traditional side? And is there any safeguards we can think about right now in order to protect ourselves? Because these products are so critical to patients. To miss a therapy is absolutely untenable for any patient or anyone in this room as Canadians to think that we'd miss our treatment. So maybe I could ask about supply. Is there a concern? Is there no concern? What are we doing for the future? I'll ask anyone to take that first.
Yeah, I'm
Jody?
happy to start. Sure. So we have an entire panel focused on drug shortages later today. So
Segue.
I think we'll see. I see you, Kristen. So obviously, when it comes to drug shortages, there's many different reasons for drug shortage. It's a very complex issue. Health Canada has now set up an entire directorate solely focused on drug shortages. So in terms of concerns about procurement, I think the one thing that I would say is we do have to be very mindful in terms of making sure that we have a predictable approach for manufacturers. I think it is important for manufacturers to be able to enter the market and to compete in the market. At the same time, we have these other things that are circulating. There's pharmacare, there's talk of bulk purchasing, and I don't think anyone knows exactly what that means. But certainly, if we get into models where there's tendering and things like that, or winner-take-all approaches, those kinds of things, regardless of what kind of pharmaceutical product it is, will lead to shortages or the potential for shortages. So I think we have to be very mindful. I think with the PCPA, I think these kinds of issues are top of mind in terms of, not to speak for the PCPA, of course, I'll let Tijana and Alan do that, but I think there is a very mindful and thoughtful approach that's been taken in Canada, and certainly we would want to see that continue.
Okay. Alan?
Yeah, and I think it's always a challenge from the public drug plan perspective when it comes to fiscal sustainability. However, fully recognizing that we can't stifle innovation in both the biologic and the biosimilar market. It's challenging because I know one of the biggest things in Manitoba through the Switch initiative has been patient support program support, not only for clients, but for physicians. So it's going to be interesting navigating as we go forward of which ones will provide the best support and service, and they might see a much larger increase of transition rates for specific therapies. I don't know if I would have any great answers to that. I think Jody has summarized it very well from kind of a national perspective. But it's making sure that there's a level playing field, at least in Manitoba, and then trying to work with companies not only when it comes down to supply constraints or if issues are popping up, if there's transitions happening in a marketplace for a specific biosimilar, is working with that company to ensure that their product still remains relevant and trying to navigate that process with them.
I think they've both summarized really well. I guess the only thing I'll add is that, we are still supportive of all these new entrants. We are not, through PCPA and the jurisdictions, we are, for the non-oncology side of things, we're really not restricting the number of biosimilars that we would put on our formula, at least in BC at this point, as long as the economics of it are pretty similar. On the oncology side of things, it's I can only speak for BC, where it's provided through BC Cancer, and they actually purchase the product, which the pharmacare doesn't purchase the product, and they have to store it on their shelves, and there's always shelf space and things like that. So the biosimilars in the oncology space across the country have been managed a little bit differently than non-oncology products.
Okay, great. And stepping into the national pharmacare a little bit, with diabetes now being part of the national pharmacare program, some provinces buying in, some hesitant, some deciding what they want to do. You know, products that are going to intersect from the biosimilar that could be then within the categories if it broadens out even more. How does that space evolve with a national pharmacare? Currently, we have 2 major categories, and it could expand. What are the thoughts on what the future could look like? Is the federal government in conversation about that and what that would look like? The diabetes list started out as a small list. They missed few, then it added more. But then when we get to biosimilars, are they added as well? Is there a dialogue on that at all at this point?
Well, the list on the diabetes drugs does include the biosimilars at this point. BC is the province that announced the Memorandum of Understanding with the federal government. However, there really hasn't been any details developed, so really too early to tell what that's going to look like.
Okay. Alan,
Yeah, I know in Manitoba we still have more questions than answers, and it's a space that we're trying to navigate not only for national pharmacare, but the national strategy for drugs for rare disease. So I think there's still lots of information that we would need to gather for Manitoba, and then see what some of the process that's happening through CDA, whether it's national formulary work, on what that may look like, and ensuring that we have the right people at the table to provide expert guidance on the establishment of a formulary, I think is essential.
Good.
Yeah, there's many unanswered questions. I think we'll stay tuned. And as Alan just mentioned, there's many CDA processes that are going to play out over the course of the next year. There's elections happening in many, many provinces. We're within the next year, we'll be having one federally. Who knows when that will be, but and whether there's a new government and whether there's a change in direction there, we don't know. So I think from my perspective, making sure there's increased clarity about what national pharmacare means and how it will roll out is one thing. In terms of the specific product list, sort of the phase 1, I guess they're calling it, the lists are incomplete. There are biosimilars and generics on there. I think on a go forward, for me, how do we make sure the cost-saving products would be added in a timely manner in the future? Because that's not really, well, the bill doesn't really say very much other than create a bunch of processes. There's no regulation-making power, it's pretty thin, right?
Yeah.
So seeing how that plays out, but in the agreements, for example, will there be requirements for generics and biosimilars to be added, right, and switch policies to happen as those products become available in the future? Because we're looking at a snapshot in time now, but of course the off-patent products will be coming to the market at some point as well.
And this dovetails into politics. Not that we want to be into politics, but where Canadians, as I said from the beginning, if I can step out of a wheelchair and be able to walk without pain every single day, if I'm not 3 weeks debilitated by a migraine and not able to go to work, function at the home, and do these things, I want those life-saving medicines, but they come at a price. And politicians are certainly trying to figure out. And I know from my experience with my former company at TEVA, looking at the drug plan and looking at the increases that we're getting each year, because more and more people are not using the several $100 solid dose old traditional medicines. They're going into these new therapy groups that are costing more, and so the program is increasing. So from a private standpoint, there is more charge every other week to the employee base on their salary, but on the public side, what are we as Canadians prepared to do? Do we want more tax? Do we want more cuts somewhere else in order to pay for them? Because the biosimilars and biologics can become much more the mainstay and not the outside part of our healthcare system. How do we pay for that? And I'm wondering, just open-ended, where you see potentially this goes between what's very good from a healthcare perspective, but how we pay that bill from a public payer, from the private payer, and how politicians bring this to the Canadians and how we decide? Not an easy question.
Not an easy question at
No.
all. I mean, you're right. The costs are going up and up and up. Some of these therapies are life-changing. We are now into, past the biologics and biosimilars, we are now into gene therapies, which appear to be effective. I mean, data is short. The time that they've been available, it's really short, so we don't know if they're lifelong or not, but we are now stepping into millions of dollars. And we'll have to work together. The politicians, the plans, the patient pairs, the manufacturers, to see how we make this sustainable for the future. And it's not just a Canadian problem, it's a global problem.
Right.
Yeah, absolutely. In Manitoba, fiscal sustainability and responsibility is one of the prime and priority ways that we approach our work. Manitoba is under significant not only budgetary pressures, but cost pressures in the health system and in the drug plan. And new government's mandate, they're a year into their current term, but new government's mandate is all things health. So, when we look at what that means, it's ensuring that we have enough docs, enough nurses, that there's access to medications, and that we're approaching things in a common sense manner to ensure that we're saving money where we can. That being said, we also have to make sure that there is access to new therapies, and it'll be interesting going forward of, how are we going to approach that in Manitoba, being a very small province, a very small tax base. We're not a boom and bust economy in Manitoba, of how we're going to navigate that. When we look at things that we'll try to do, I know there's been some talk of trying to work in a little bit more collaboration with our health system on current therapies, and with the biosimilar switch initiative being rolled out, are the ways that we can navigate with the health system on maybe making biosimilars more of an option number one versus an option number two in certain therapeutic spaces, realizing that there may be initial upfront cost to a drug plan, but might be able to save a lot of health system costs down the road. But a lot of that's going to come down to breaking down some of the budgetary silos that are in place, and being able to navigate with some of our senior leadership on what that may look like, that increase in expenses in one area can lead to significant savings in another.
Yeah, thank you.
Yeah, well, the value proposition for biosimilars and generic medicines is to create headroom, is to help to support the sustainability of drug programs, to enable drug programs to fund innovative new therapies, but they may also, and we've seen some great innovations in terms of the drug programs, in terms of expanded reimbursement criteria being applied to biosimilars. So, maybe a jurisdiction wasn't able to cover a particular product for the full, range of indications, or, to start treatment earlier, as may have been recommended. It was sort of a narrow coverage. So they've actually expanded the coverage for biosimilars in several instances, which I think is great. We've also seen other kinds of health system, efficiencies and cost savings that have happened. So removing annual renewal requirements is something we've seen some jurisdictions do for biosimilars as well. So that removes the burden off of the clinician, and is also helping the system operate more efficiently.
Good. Well, we've just got under 7 minutes left, and I want to turn it to you. It's your opportunity to talk to these panelists, these experts on biosimilars, the category, and broader. So I extend to you to put up your hand, and the microphone will be brought to you, and before I have some closing questions. So,
there's a question over here.
Hi there, Will from Sterimax. Alan, you briefly mentioned non-biologic complex drugs. I was wondering if you could compare and contrast the rollout of interchangeability between non-biologic complex drugs and biosimilars.
It's been challenging and difficult to navigate. In Manitoba, we were the last one, the last province to roll out our biosimilar switch initiative. I know there's a specific drug that has been kind of caught up in that when it comes to, there's a biosimilar and there's also a generic option. And it's been a challenge. I can't say too much because of confidentiality, but when we look at it, a lot of that comes, a lot of the situation happened because of not only the regulatory pathway, but also the CDA pathway that was involved. And it's no fault of anyone's, it's just the way that it played out, but we've kind of been caught in the middle of that. And I know for ourselves, pricing can be very different when we're talking about biosimilar space versus the generic space. So it's something we're trying to navigate with the companies involved. I know, our policy that we rolled out in that space has been, in support of a biosimilar switch, not going down the generic pathway, but it has created some complexities. So, in going forward, that's something that we would really like to see, is that that approval pathway is very distinct and has been set from the beginning to remove some of that ambiguity that's happening, and then some of the impact that may happen on the company that decided to go down the process of having a generic versus a biosimilar product.
I can just add something to that. It's a really interesting space because now that's a very specific case that we have there, but for biosimilars, we have very clear policies that have been effective, and that's you delist the originator product. So you go through transition period, you delist the originator, which really stimulates the uptake of biosimilars. And from policy perspective, that's been super effective. We don't have the same thing on the complex generics. And that's been a big challenge for the uptake of those products. For some of the things that we've discussed here about the patient support programs, the specialty pharmacies delivering specific products. And so we are not seeing, without that delisting, we are not seeing the same uptake on the complex generics. And certainly something that, me and my team, we keep thinking about what do we do about that.
Good, thanks. We probably have time for one, maybe two more questions. Anyone from the audience with another question? Is that after lunch thing? I completely understand. I understand. So maybe I'll ask the panel one last summary question. That is, if you were to put a report card on where we are now, we've transitioned to biosimilars. Every province, jurisdiction, even outside of provinces, is now doing the switch program. Where would you put us? If you put us on a scale of 10, you say we're 8 out of 10 or 6 out of 10, maybe give us some reasons why, and this is sort of the summary of our panel discussion. So maybe Dr. Tijana, I can ask you to start off with where you think we are from a scorecard standpoint.
Okay. I think this scorecard has a number of categories, but I think from the uptake of biosimilars, we're pretty high up. The support for them, they're coming, that's really high up. Where we are still maybe in a 5 is the education and the acceptance in the healthcare community, in the patient groups. I think there's still work to be done there.
Okay, thank you very much. Appreciate it. Alan.
Yeah, and I'd probably say like a B to B+. I think it's been really positive now that Manitoba has joined the rest of the country in supporting biosimilar switch initiative. In agreement with Tijana, I think one of the biggest things that we didn't have visibility on when we started was patient support programs, the education component, infusion centers and how that's working. And so in navigating some of the rural and remote aspect, that's something I think we can really improve on. I know in Manitoba we'll be spending a little more, attention on and focusing is in that specific space to, try and help guide patients as best we can to ensure that rural and remote patients have access that they need. But I think we've done a pretty good job now that, Manitoba has joined the rest of the country.
Good. Jody.
Yeah, so even though I think we had a slow start on biosimilars in Canada, we've grown by leaps and bounds. So, today there's almost 3 million retail biosimilars prescriptions filled with every year. It's a $2 billion market. So that's significant growth in the market. I think, we've gone from learning from other jurisdictions, especially the European jurisdictions, and building on their real-world evidence to building our own real-world evidence here in Canada. And now we're sort of a jurisdiction that countries are starting to look to in terms of best practices. So I think that's quite an accomplishment. In terms of other issues, certainly it's a bit of a mix on the private side, of the private market, so there's more that can be done in terms of uptake on the private side. The pharmacare provinces do very well. Quebec has strong alignment, but in other jurisdictions, there's more to do. So I think a B is probably good, B plus. We can't stop now. There's much more to do in terms of ensuring predictability and sustainability, but we're off to an excellent start now.
Good, thank you. And no other questions from the audience? Going once, going twice. I want to thank the panel very much for talking about biosimilars and where we are as impact. And Tijana, as you had said, maybe by next year at this time, we'll not only see where the biosimilars are in 12 months, but gene therapy and the new therapies that are emerging are going to be those topics that we're talking about today as biosimilars. So I thank all of you for being with us today. Thank you again. Appreciate it. And the panel. Thank you.